Case one, a 48-year-old male comes to your clinic. Percentage? Oh, no. Chief complaint, left heel pain. It's too small.
Complaining of.
Yeah, well, heel pain for 7 months. He denies any specific trauma to the heel or foot. NSAIDs provide temporary relief, but overall pain has been getting worse. In general, the pain is 7 out of 10 when he takes his first steps in the AM or after sitting for 30 minutes, then diminishes as he moves around. He additionally, Chief complains of increased pain when standing for over 20 minutes. Though he's 57 pounds overweight, he enjoys walking 35 miles a day and hopes that this type of exercise will help him lose weight. He's recently had to stop his walking regime due to pain. His goal is to return to walking 4 to 5 weeks.
Regimen. His goal is to return. You know the difference between regiment and regiment, but we'll get to that another time. His goal is to return. Good. Based on this patient's report, what do you say the diagnosis is?
Plantar fasciitis.
Say it loud, please.
Plantar fasciitis.
All right. Name 2 intrinsic factors for this diagnosis.
Intrinsic, low arches with too much motion is in rear foot and midfoot, and the high arches when there's too little motion in rear foot and midfoot.
Good. So you could have it with low arch or high arch. What are 2 extrinsic factors for this diagnosis?
Spending too much time standing, or we have poor footwear and BMI above 25.
Yes, his BMI is 25 to 30, spending too much time in standing, and poor footwear. Poor footwear meaning he needs to replace his shoes. I don't want Carlos to get angry at me. Based on the patient's report, what 3 activities would cause this patient's pain?
Prolonged standing after prolonged activity and first steps in the morning.
Yes, first steps in the morning, prolonged inactivity, prolonged standing. Good. Now, assessment. I'm going to say it for the 20th time. When it comes to goniometric or manual muscle test, you will be responsible for all ankle goniometric assessment and manual muscle testing. We will not do it on this video for an interest of time, though you know how to do it. All right. What specific range of motion will be limited during passive range of motion testing?
Dorsiflexion and hip flexion.
So dorsiflexion due to tightness in what?
Gastroc and soleus.
Good. And hip flexion due to?
Tight hamstrings.
Very good. Who cares?
Wow.
Why do I care? What does this have to do with this diagnosis? Those 2 tightness.
His tight hamstrings reduce terminal knee extension during heel strike, which increases forefoot pressure.
Yes, so if the patient is lacking, it has hamstring tightness, it affects terminal knee extension. If terminal knee extension is affected, it affects heel strike. When heel strike is affected, it can create the plantar fasciitis. Excellent. And dorsiflexion, like you said, the same thing. If dorsiflexion is limited, it will affect how heel strike occurs. That issue over long periods of time can create plantar fasciitis. Very good. Special testing. Share with your audience 2 specific tests to use to rule in this diagnosis.
So we have
Show us.
So we do the 90-90.
A 90-90 straight leg raise test, which is used to test what?
Hamstring tightness.
Hamstring tightness, which is specific to this diagnosis. Okay.
Patient will lie down. We'll have patient bring up both knees 90 degrees. You can put your hands behind to hold up. Okay, 1 at a time. We're testing, do the right leg. Okay, I'm gonna extend the knee, see how far I can take her.
This is an active test.
Yeah.
This is,
Right? Is it?
Yeah,
It's
yeah.
active.
I'm gonna do it.
She's
next.
It's
doing
an active
Okay.
test.
Okay, so here, one,
Oh.
and
And then, yes, and the therapist will
this is
look
tight.
at both
Look at the
and
difference.
see if one is
This is
there's
tight.
knee flexion,
Yeah.
there's tightness.
Yeah.
Good. What's another special test?
So ruling.
the windlass.
The
Windlass
windlass
test.
test. So this
So
one, the
this-
patient is standing on a surface. We're gonna use not a chair, we'll use, let's use a step or that, right there. The patient puts 1 foot on the step, the other foot, I don't care where, on the floor is fine. And the therapist, this is a passive test.
The therapist will place their finger under the big toe, the LCS longest, and we are going into extension. Okay, seeing what she has, stiffness or pain.
So you're not
Oh.
looking for a range of motion, you're looking for what? Yes, complaint of symptoms.
Yep.
that brought the patient here, correct?
Can you keep pressing your foot down? Yeah. There you go.
Good. Why would this be a positive test if the patient has plantar fasciitis?
Because they tend to, the fascia under the foot is tight.
So what does the toe extension do?
Toe off helps you
What does
propel.
toe extension have to do with plantar fasciitis?
It makes it
I think
taut.
Gus said it. What did you say?
It's making it.
Yes. Thank you.
Like
From
a
he's from
fight.
Canada. Toe extension, when you extend the toe, it makes the plantar fascia totally taut,
Yes.
right? Super tight, which is what it naturally does anyway. So if you put the toe into extension and the patient has plantar fasciitis, it will recreate the symptoms. Does that make sense?
Yes.
Yes, very good. All right, you guys mentioned before that a low or high arch can affect this diagnosis, right? So show us a way to test or to measure rather the patient's medial longitudinal arch. So for this one, they can be sitting or standing, but you really start in sitting and then you
Yeah,
do it
they-
again in standing. So let's do it in sitting.
Okay.
So the patient is sitting. No, the patient's foot must be flat on a surface.
Oh,
So
okay.
that might be too high. If you have them sit there and then place their foot on the step, that will be perfect. You see, this is a good way to do it. So you place the, that's not for you to sit on. That's for the patient's foot.
I don't want to squat.
If you don't want to squat, then
Perfect. This feels
figure
good.
out another way to do it.
All right, you
What are the bony landmarks for this? What's
So-
the first bony landmark that you're gonna mark off?
So the apex of the medial malleolus,
The apex of the medial malleolus?
Center.
or the
The
center.
center of the medial
I
malleolus.
watched the wrong video. So
What's the next bony landmark?
navicular tuberosity.
Yes. Do we know where that is? Is it marked off now?
Yes.
Okay, and then the third?
And the base of the first metacarpal.
Metacarpal, that's.
Metatarsal.
Oh, okay.
Metatarsal.
The base of the first metatarsal head, which is where it's all marked off?
I'm
Very
learning,
good.
I'm
These are the
learning.
spots. So on the practical, I'm going to expect you to mark it off. That malleolus, is that in the center of the malleolus?
If she's standing, it might look
It shouldn't matter. It shouldn't matter. The center is the center.
All right.
Yes, the center of the malleolus.
The
Good.
skin was pulled
The best
over.
part is that you practice this before we go on video. That's the
Okay.
best part. Good. Those are the three spots, correct?
Yes.
Good.
Okay.
Where do you put the center of the goniometer?
The fulcrum is by the navicular tuberosity.
The center or the fulcrum is the navicular tuberosity. Good. Where does one line or
The,
whatever?
the moving arm is at the malleoli, center of malleoli. And the non-moving arm, a stationary arm, will be parallel to the.
Aren't they both stationary? But that's not right. Anyway, it doesn't matter. Good. And then you take it and you read the patient's angle and what is considered a normal arch.
So she has 149 degrees.
All right. So what is normal? Say it loud.
132 to 152.
132 to 152 is normal. So you have a normal one, but that's you. And then, and what is considered a low arch?
Below 130.
Below. Huh?
Correction is 131 to 152.
131 to 152, and below 131 is below 131 is a low arch, and above 152 or 153 or higher is a high arch. Good, excellent. Differential diagnosis? What would you perform to rule in or out tarsal tunnel syndrome?
Compression.
So you take the foot to the available, the most plantar flexion you can get. A little external rotation. What it was? No. Inversion.
So max plantar flexion and inversion.
Inversion. And then you're gonna compress on the tibial nerve, and it
Yes.
should.
Well, is your X-ray vision working today?
So that will be below and posteriorly of the medial malleolus.
So posterior to the, let's say the center of the medial malleolus, let's go a little posterior there. and that would be where the tibial nerve is. And how long do you compress for?
30 seconds.
30 seconds. And a positive sign is
Pain.
where?
Well, numbness on
Where?
the toes and fingers of the foot.
The
And plant.
The plantar surface or the dorsal surface? Which surface?
The plantar foot.
Plantar surface by the metatarsals, perhaps, right?
Oh, okay.
So a patient can have tarsal tunnel syndrome. The tarsal tunnel, the tibial nerve goes through the tarsal tunnel. If it's being compressed there, the
Where do you
patient
feel
might
it?
have symptoms in the center of the foot or by the metatarsals, and it might be misdiagnosed as plantar fasciitis when in fact it is not.
So
Does
it's
that
the
make
whole-
sense? Does that
the
make
whole
sense?
thing? Okay.
That make sense?
But you feel it here too.
Yes.
All right, you got it? Okay, so let's assume this patient has a low arch, okay? What muscle would you have to strengthen to help? What's the most important muscle and the most important bone for the medial longitudinal arch?
Tibialis posterior.
Yes, and it attaches to the tibial tuberosity and the navicular, not navicular tuberosity rather, the navicular bone is the most important bone of the arch. It actually has a lot of movement to it. If the posterior tib is weak, that could be a reason why the patient has a low arch. Okay? Excellent. So let's now treat the patient now that you found everything, all right? We're doing a 2-session plan of care, is that right? So we're first gonna teach the patient to stretch hamstrings, hamstrings, gastrocs, and soleus in the non-weight bearing position, right?
So the patient will pull his foot towards her while keeping the knee straight, and that will stretch the gastroc.
That stretches the gastroc in non-weight bearing. Good. How we stretch the soleus
If
in
you
non-weight
wanna
bearing?
stretch the soleus, you have to flex the knee a little bit.
Excellent.
You can place the towel.
Good. And how would we stretch the hamstrings in a non-weight bearing position?
So she will do like a straight leg raise.
You can use the towel.
Yeah, you can use the towel.
And we're expecting you to teach the patient, correct, for the practical?
So keep your knee straight and pull it the most you can and hold it there for 30 seconds.
Keep the hips on
You
That's the boss right there. All right, good. Now you're gonna show. Now that's a good stretch. Now let's talk about some joint moves, right? The talocrural joint posterior glide, right? You want to show us quickly the body position for that, facing the audience? Let's
come this way.
Oh, but Georgie!
That's great for the clinic.
Resourceful.
All right, so
You got a good
talocrural posterior glide.
abduction.
So it's the position. Because the other group has a similar glide, so we'll show it here so you guys won't have to show it when you do it, all right? So, you stand to the side, you stand on the lateral side of the patient's leg, right?
So you come.
Your hands are cupped under the patient's calcaneus,
Yeah, here.
but you're standing on the lateral side of the patient, hands facing this way, hands facing the other way. Good, stand on the side of the patient. And now now that's where you have the distraction, right?
So you go below the malleoli
Don't look at me.
and
Not, I
to
mean, you
find
can
the
look at me,
because
but
you have to press on the talus, right?
Looking at the camera.
Don't press on the tip. Right?
No, we're good. We're good. Yeah.
Then you distract. I don't know. I feel better like this way. Can I?
Well, we're gonna teach my way, and then you
Okay.
can do it any way you like. But on the video, we're gonna do my way, okay?
Okay, so you distract the calcaneus and press on the talus, and if it's grade 1.
Yeah, so see, with Jorge's right hand, he's, Georgie's our last class. I don't care anymore. We're going back to day 1 with everyone's names.
I'll do the other way, man.
Georgie is
he said to do it this
do
way.
it that way. I don't care as long as
Oh.
you're pulling on the calcaneus and you're distracting, and then you're doing a posterior glide of the talus
The talus, not the tip fit. The
on the
talus.
distal tip there. You got it?
This is going well.
You push down and you oscillate.
Whoa, whoa, whoa.
Good. That will be a talocrural posterior glide, right? Hello?
Yes.
Good. Now, how about subtalar joint distraction?
So that will just you stabilize here and
Yes,
distract.
and what two bones are involved in the subtalar joint?
That's the
The
talus
sulcus.
and calcaneus.
Very good. And finally, an AP and a PA glide of the first MTP, and also a distraction of the first MTP.
Sure, sit.
Oh.
That's a birdie.
Somebody else did it.
Birdie, stick birdie. Oh, sorry.
Yeah, I don't want to degrade it. I want to make.
All right, so
All
this
right.
is a distraction we did not. This is a distraction in joint mode that we did not learn in the joint mode class, right? So when you're doing this, you are what is moving on what?
It's concave on convex.
It's concave on convex. We're gonna do AP and PA just to loosen up the whole joint, because ideally though, you need first toe extension when you're walking. The research likes AP and PA just to loosen up the whole joint. But realize, if you're working on extension exclusively, are we doing a dorsal glide or a plantar glide?
Dorsal.
A dorsal glide, very good, because it's concave on convex. And distraction is the same thing as the CMC joint. Show us distraction first.
Extension is a dorsal, right?
Extension dorsal, yes, same direction.
So you grab on the base of the metatarsal, and just above the joint, you pull on the proximal phalange.
Were you looking before approval?
Don't let me
And just
Yeah,
distract.
you're pulling, yeah, you always move distal on proximal, so you're pulling the interphalangeals on the metatarsal phalangeal joint. Very good. Now, show us an AP and a PA glide. So distraction, and then, just like the wrist, you distract, and you go into a PA or an AP glide.
Okay. So
Distract, show us a posterior glide or a plantar glide. Good, you see, he's not doing flexion, he's going straight down, remember that? And now distract again and do a dorsal glide or an anterior glide straight up. You're doing both, excellent. Now, show the patient how they could do a technique on their own to loosen up the plantar fascia. Well, you can show the patient how you do it on them, and then show them how they would do it on themselves for a home exercise program. Who's the patient? Good. So the patient is seated, and the therapist sits next to them. And please have no sock for the treatment if possible. Excellent. And the therapist will extend the big toe. It's a must. If you perform this technique without extending the big toe, you're not working on the patient. And then what are you doing?
And then dorsiflex.
No, where's the manual technique?
Oh, right here. We don't do-
The
Ma-
manual.
fingers here.
Just the fingers, right? Or like the palm of your hands going up.
So first, big
Big
toe
toe.
extension, and you're doing a manual technique on the plantar fascia. Do you see that? Yes, do you see that? Yes. And how would the patient do it on their own at home for home exercise? The patient will sit, cross one leg over the other, do their own first toe extension, and then work on it the same way the therapist does. If they don't do big toe extension, you're not doing it properly. Everybody get that? Good. Now, you mentioned the patient has a low arch. Did I skip something?
No.
The patient has a low arch. Show us an exercise that they could work on their arch, working on the posterior tib.
That's the penny and the peso.
Yeah.
Thank you.
It's it's money and a pen.
Sorry.
So the penny
Peso
and
and
the
the
pen.
pen.
The peso and the pen.
Okay, we're doing
We'll let it.
All right.
Okay.
So the patient, yeah, go for it.
Peso goes under here. Base the first metatarsal. Place it on. Go ahead.
Just right
Sit.
here, right here.
Yeah, go
Goes
ahead.
on the base of the first
Yeah, yeah.
metatarsal head,
Uh-huh.
right?
Yep. We place the pen directly under the medial longitudinal arch. Up there.
Okay.
Okay.
And if you look at her foot, her back foot is on, the foot that's not being treated is behind the foot that's being treated. Both
Can't
feet
bend.
are on the floor. Yep.
And then we're gonna ask the patient to try to scrunch your foot, try to bring your arch over the pen.
Just make it simple. Try to keep your arch away from the pen while your foot has to touch the penny.
Keep it on the penny.
Your foot must touch the penny while you take your
Yep.
arch off. There you go.
No,
Move the
No.
arch off
No.
the penny while keeping.
she's cheating.
Oh, yeah.
I'm bending my knee. Okay, it's not
You
really.
can't lift if you're lifting up.
Bending her knee.
Okay, I'm not gonna
raise
do
it.
it now.
Oh.
There you go.
Alright,
There you go.
it's a
There you
good-
go.
So
There,
catch that.
there.
Don't bend your knee.
I'm not on camera. You are.
Right there, right there.
Using technology.
There. There's it. Now the arch is moving. Before her knee was just bending,
Oh, you-
raising her foot off the ground.
Right.
Got it. So that's why you need the penny as a point of reference, so that the patient's first metatarsal head must remain on the penny. Phase 1 is good because both feet are on the floor.
Phase
Right,
2
the
would be
unaffected
just
foot
single
is
leg
behind the foot that you're treating. Very good. This is known as what? Tandem stance or something? All right.
Yeah.
Now, the ice cup technique is what I will ask for this case. You don't have to show us. Watch the video. Somebody, I think in procedures 2, forgot to take the top of the cup off,
Yes.
which was not. Oh, I don't know if that person was in this room. I forgot who it was.
They're not in this room.
They're not in this.
Sorry,
Oh,
sorry,
wow.
sorry.
Wow.
You kick him out, it's elastic.
But yes, you must take the top of the cup off to treat. Okay. Okay.
Hole.
Now we are stretching and weight bearing.
Broken?
How do we stretch the gastroc on the soleus in standing?
Standing, you can bring your fingers to your
That's a
nose.
gastroc and soleus stretch.
Oh, sorry, sir.
Yes, runner's stretch.
And then bend your knee.
Runner's stretch, back knee totally straight is for the gastroc, back knee bent is for the soleus, and now weight bearing for the hamstrings. That works for me. Okay. The same joint moves for phase 2, but now they are 3s and 4s. Okay, everyone got that? 3s and 4s for all the joint moves and the distractions. Not 1s and 2s like in the earlier phase, but now 3s and 4s. Good. All right. How would you make the manual technique that you did on the patient more aggressive? Use the knuckles, right? Same thing. You do first MTP extension, and now you use your knuckles. And when the patient does it on their own, again without a sock, first MTP extension, and they're going to use their knuckles. All right, that's more aggressive. Very good. Now the penny in the pen. How will we advance that? What would you do to advance that?
Position patient, single leg.
Single leg stance would be the advancement in phase 2. Much harder when you're standing on one foot. Very good. And the standing ice roll, you just take the roller, put it on the floor, roll on it, right? Very good. Any questions from this group, for this group, by this group? Question? No question. What are we doing now, Carlos? 1 or 2?
2.
Let's go, Cat. Okay, Cat.